Yes,
Sonny,
sir.
can you hear me?
1 second.
I don't know if that's you, Sonny, in the operating room talking.
I can hear you loud and clear. How about me?
Yes, you can hear me?
Yes, sir.
Are we live?
We are live. Yes.
Live now?
Yes, sir.
All right. Well, good morning, everyone. This is Dr. Ara Deuk-Machen, CEO and founder of Deuk Spine Institute. If you're watching live today being the 2nd of July, 2019. So if you're watching on the 2nd of July, 2019, you're probably watching a live stream of spine surgery from Deuk Spine Institute and the Surgery Center of Viera. Our patient today is having a Deuk laser disc repair, cervical, for 2 herniated discs in her neck. She's been having a lot of pain in the neck that goes up into her head and down her left arm. She's having arm symptoms of cramping, numbness, tingling on the left side. No right-sided symptoms. You'll notice that the drapes are a little different today because our patient has an allergy to iodine, and normally our drapes are impregnated with iodine. So today they're not. The first thing I'm going to go ahead and do is feel her neck and check with my anesthesiologist, make sure her vitals are good, she's stable. How is she doing? Okay, good. And fully relaxed? All right, very good. So what you're seeing, so Luis, this drape should never be right here. It should be down here, okay? Off to the side. This is too close to where I make my incision.
Yeah, that's the second drape that I put because I don't want the water going to the...
Again, the drape needs to be here.
Yes, sir.
Okay? This is fine. This is fine. This is fine. This, I'd like it a little bit more lateral, about, I don't know, a few millimeters. So first thing I need to do is, we already did a timeout, and we've already done, I think, 3 or 4 of them by now. And first thing I need to do is just feel the neck. I'm feeling for the spine itself. I could feel it very easily with her. So that's a really good sign, because it's not really safe to do the surgery without actually being able to feel the spine with your fingertips. And the key to being able to do that is, of course, the patient has to have a nice neck, a nice thin neck, but also the patient has to be fully relaxed. So, all right, we're doing number 5, 6, and 6, 7, correct? 5, 6, 6, 7, everybody in agreement?
5, 6, and 6, 7, that's it.
All right, let's go ahead and get a lateral view. All right, so 2, 3, 4, 5, 6, 7. I'm at 6, 7. So I really like to make my entry point, if I'm doing a 2-level, at the vertebral body in between them, and then just move the skin up and down. So shot. Right now, shot. That's it right there. 2, 3, 4, 5, 6, 7. All right, shot. So I'm moving, but we're not moving the needle. Shot. That's better. All right. So that'll be my entry point. I'll slide it down. Shot.
There's anybody that actually...
Shot.
In case we need to pull the shoulder.
Uh-huh. Shot.
In case we need to pull the shoulder.
Give me an AP view. That's a quick AP. Looks like we're off to the side. I need the lights down. Why are the lights still on so high?
Lights down, this one as well, please. A little bit. And the
Shot.
lights. There you go.
Lateral. So now I'm happier with the tip. The tip is actually in the midline. Before it was a little bit off to the side in the longest coli muscle. Shot. So Sue, if you're watching this video after surgery, you're not giving me a lateral right there at 6, 7. 2, 3, 4, 5, 6, 7. I'm not seeing a lateral shot. You see how the end plates are not lined up at 6-7? Shot. Your end plates are not lined up at 6-7. Shot. What are you doing to fix that? You need to wag. Shot. Sweet Jesus. Shot. Give me an AP. How's our blood pressure? So as part of the surgery, I do get to radiate my hands. You know, they used to treat acne about 100 years ago with radiation to the face to treat facial acne. It actually caused a lot of brain tumors. What do you think about that picture? Huh? Jordan, what do you think about the picture? What? It's rotated, right? So you need more of a true AP there. Anyway, they used to treat acne years ago with radiation to the face and head, and all these kids that when they grew up, they ended up with brain tumors, and we realized, crap, radiation's not good for you. Maybe we should stop treating acne with it. And anyway, part of this spine surgery is radiation. We try to minimize it. That's good. Go to a lateral. So obviously the patient, we worry about the patient amount of radiation they get during the surgery, but we also worry about the amount of radiation the staff gets, including the surgeon, me. And those are all very important considerations when you're talking about the kind of spine surgery you're doing. So most spine surgeons, so Jordan, you see, when you're before you even get in the room, you've got to make sure the end plates are lined up at the levels that I'm treating. So what do you think about the end plates at 4-5? First of all, you're overexposed, way too much. But what do you think about the end plates at 4-5? It's perfect. It's perfect. What do you think about the end plates at 6-7 where we actually need to operate at? It's pretty good, but it's not perfect. So you need to be getting the end plates perfect where we're operating, not at levels away from where we're operating. Because if it's perfect at levels away from where we're operating, then what's going to happen is you're going to get parallax, which means we're going to have not a good view where we're operating. How's our blood pressure? All right. That's good? All right. I'm happy with that. Let's go ahead and do our discogram. So radiation, very, very important, folks. Those of you who have had spine surgery or need spine surgery, important consideration for you. You don't want a lot of radiation. A lot of radiation is very, very bad. And we're not going to be able to see anything because we're not putting iodine dye. So this patient is actually allergic to iodine dye. And because of that, we cannot use Omnipaque, which is our typical dye. And we can normally see where the dye is on the discogram, on the x-ray, because it's radio dense, radio opaque. And that just means that we can see it on the x-ray because it blocks the x-ray. Shot? All right, that's good. Now again, you're overexposed. Are you pulsing or not? Good. So folks, this radiation thing, since we're going off on a radiation tangent here, we're going to talk about radiation today. Radiation is very important. I can assure you that 95% of spine surgeons don't even think about the amount of radiation that the patient's getting or that they're getting. Why? Because it's just not really talked about during training. It's not emphasized, it's not prioritized, but it's important, and it's something that's overlooked in spine surgery. I think interventional pain management doctors think about it a little bit more than than perhaps spine surgeons do, but it's very important. And I can tell you, I've seen the radiation numbers in spine surgery. And for open spine surgeries, they're typically about 3 to 5 minutes worth of radiation. 3 to 5 minutes worth of radiation. It's not enough probably to cause a tumor or cancer, but it's a substantial dose. And the thing about radiation is that radiation dosing is cumulative, meaning if you get, you know, 6 gray of radiation today, and you get 6 gray of radiation 2 years from now, then you've really had 12 gray of radiation, and the cumulative effect of radiation is on DNA. It causes a DNA mutation. DNA to mutate. When DNA mutates, it means it changes. And mutations mean that there's changes in the base sequence of DNA. And that's how cancer is formed. Is there epi in there?
Yes, sir.
So when you start changing DNA sequences, you change what cells produce. Because DNA is like a recipe for what a cell will produce, what it will make. And I can tell you right now, once you start mutating what a cell makes, cell starts making abnormal proteins and enzymes. And then it starts to grow out of control, form a tumor. And then a few more mutations later, the cell becomes metastatic, cancerous. It starts to detach from each other. They lose adhesion. And then they invade blood vessels, and they actually grow into the blood vessels and then get seeded throughout the body. Once you get into the bloodstream, the tumor cells just spread everywhere. Or they get into the lymphatic system and they spread everywhere. So what I'm trying to tell you is radiation's bad. Radiation's used in spine surgery for every single spine surgery case in the world. However, what you want is a surgeon who uses the least amount of radiation possible for you as a patient, but also for the staff. And I can tell you, surgeons normally are very abusive with the amount of radiation because they're not thinking about it. They don't care about it. They're not trained to care about it. All right, so we're heading down to C6, 7 shot. So 2, 3, 4, 5, 6, 7. And I feel like we're still overexposed there, Jordan. Maybe we can reduce the amount of radiation or use your collimators to focus and reduce the amount of exposure of radiation. Shot. All right, so we're right in the front of the spine with the dilator. If you need to get Monica in here, get Monica in here. Let's go ahead and get Monica in here.
Autumn, 8,000 extension.
Shot. I just want to make sure we're really overexposing right now. She's got a very thin neck, very little soft tissue. We're not giving her dangerous doses of radiation, but it's when you have less tissues to go through, the radiation penetrates easier, and it kind of washes out in a white color everything. That's better. That's better. What did you do?
Took off the tech lock.
What?
Took off the tech lock and I lowered it as much as I could.
All right, good. Well, that's perfect right there. That's perfect. You don't need Monica anymore. Jordan figured it out. I think we're good. Give me an AP.
Your fingers are sticky or are you good?
My fingers?
Yeah.
Are you accusing me of stealing something? Sticky fingers? No, my fingers are fine. There's no Omnipaque. Omnipaque is what makes the fingers sticky. And we're not using Omnipaque because she's allergic to iodine. All right, that's perfect. So the tip of our dilator is dead center in the spine. I love it. Couldn't be better. It's right over the spinous process line. And the direction is to the patient's left foramen. Go back to a lateral. So this is the bottom disc. We're going to fix this one and the one above. And again, you're not seeing any dye on the discogram as you normally would if you're one of our regular followers. And the reason is we don't have iodine. You need iodinated dye to be able to see things on X-ray. Shot. All right. So we're ready to get started here. I'd like you to move north just about half an inch so I can see the top of C2. So for those of you wondering, how do we know where we are? We count down from C2. If you look at the top of the screen, C2 is that vertebral body or vertebrae that doesn't look the same as the ones below, and that's number C2. It's got a big spinous process as well. And the one below that's 3, 4, and then 2, 3, 4, 5, 6, 7. We're at 6, 7. All right, so I like to advance this dilator through the disc with my fingers by using a twisting motion rather than a hammer, just to get it started. Shot. And I'm going through what's called the anterior longitudinal ligament. Shot. All right. So you don't want to just push through suddenly because you could end up going too far. It's very unlikely, but go ahead, shot. So I'm pretty much anchored in. I'm going to have to, because I can't push it through, take the dilator out and get in and just start. Shot. Shot. Perfect. So we're at the back of the disc now. I'm going to put in the tubular retractor. So the whole surgery, folks, is done through this tiny tube. Amazing, isn't it? Now, anywhere else in the world, because I really am probably the only surgeon in the world that's doing these endoscopic anterior cervical cases that are transdiscal. But this is an incredibly technical and difficult surgery to do. I just make it look easy because I've done so many in 13 years. But don't try this at home in your garage. But the whole surgery is done through this tiny little straw. The outside diameter is 4 millimeters. So the inner diameter is about 3.4 millimeters. So the entire surgery is done through a 3.4 millimeter diameter tube. Now, if we're doing a fusion like every other surgeon or an artificial disc, there would be a big incision. You'd have to move all this tissues over, and there'd be difficulty swallowing, pain with swallowing, possibly nerve or blood vessel damage, a lot of scar tissue. You don't get any of that with the Deuk laser disc repair. All right, so now I've got to advance this tube all the way down to the spine, and then we're going to push it right through the disc, over the dilator. Shot. We were just getting a little bit overexposed, but he figured it out. So I'm happy with the quality of images right now. You can see everything good. Yeah, really nice. So we're good. If you want to leave, you're welcome to. Shot. All right. What are we listening to? Pop?
I don't know what station I turned to.
Yeah, let's put on something else. Do we have an iPhone or something? iPad? Shot. All right, that's good. So there's a little bone spur up front. We're not worried about that. Hair Nation, you could try. Yeah, salt and pepper, huh? Shot. So you can see the tubular retractor is just going into the disc space at this point. And again, we're not worried about a bone spur in the front of the spine. The only things that cause symptoms are the herniations and bone spurs in the back of the spine. And that's what our focus is today. Shot? Yep. Perfect. Shot? You want to make sure as you're advancing your tubular retractor that your dilator doesn't advance. Our dilator moved just a little bit there. You can see it moving. So we just need to be careful about that. Shot. Shot. Better. Shot. Much better. Shot. Good. Shot. And I just love this patient's neck because it's so perfect to do surgery. She's fortunate because with such a perfect neck, she, in my opinion, the surgery goes smoother and easier. So, shot. She has a nice thin neck. All right. We now have this tubular retractor tip at the back of the disc, right where the herniation is. And that's the beauty of the surgery is you don't have to take the whole disc out to get to the back part like every other surgeon in the world does when they do an open anterior cervical discectomy or they do a artificial disc. Okay? So you can all see the entire surgery is being done through a 4 millimeter skin incision through a tiny tube. And again, this looks like an easy surgery to do, but it's not. It's probably the one of the most complex types of spine surgery there is because there's so much at risk in the neck with your carotid artery, jugular vein, the trachea and esophagus that you really have to be like literally perfect with your technique And there's a lot that goes into it. It's not just the surgeon's technique, but it's also the anesthesiologist. Where's my irrigation? All right, better. Let's go ahead and grab some out, and let's lower the lighting. I think we're overexposed. We need a little light back here. Let's go.
Right here, please.
Give me some kind of light. All right, that's too much on the field. You guys, the same, yeah. Right here. Turn, turn, turn. Maybe right there. All right, that's better. Okay, I need the grabber. Where's the pituitary? All right, good. Okay, you ready? So there's a lot that can go wrong with the surgery. This is not an easy surgery, so don't think, oh, small incision. I'm a pain management doctor. I do things through small incisions. I could do the surgery. This is incredibly complex surgery for a spine surgeon, which is why there are no spine surgeons that do this surgery besides a few of us in the world. And I think I'm the only one now because the Koreans stopped doing it. Why do we have no irrigation? Please don't do that clamp in the future. I don't want to have to do that. So I'm using a laser fiber, and you see the laser fiber at 12 o'clock. And that laser fiber is connected to a holmium YAG medical laser. And I'm going to use this laser fiber to remove the herniation. What you're seeing there, the blue dye, where's my pedal? The blue dye, thank you, is actually the dye we injected with the discogram. I need, let's see, I think the brightness is good. I think we're okay. That's the annular tear right there, folks. That's the actual tear in the back of the disc where the herniation is. And the blue stuff is the herniation. So already we're getting some fragments coming out. So my surgical goals here are to remove the herniations, all of those little fragments right there. You see that? Those are herniated fragments. They're coming back into the disc space because I created a hole for them to come out. Remember, these guys want to go through what's called a path of least resistance. So I just created a path of least resistance for them by putting this tube in. Once the tube goes in, then I've created a way for them to get out. They're like little trapped prisoners. They've been squeezed out of the disc space through the tear, the annular tear, to the back of the disc into the epidural space where the spinal cord and nerve roots are. And that's why they're creating so much problem. They're creating all this inflammation for the patient. And that's how she feels all this pain and suffering, is because of the inflammation within the annular tear. Okay? So for those of you who are knowledgeable about spinal anatomy, really knowledgeable about spinal anatomy and physiology, you'll know that the disc itself has no blood supply, at least the inside of the disc, and then the outer half of the annulus has no blood supply. So there's no possibility of inflammation within the disc. There's no possibility of inflammation in the inner half of the annulus, only in the outer half of the annulus. So when you start thinking about it, you realize, well, you have to have inflammation to have pain, neck pain. You have to have the inflammation to have the headaches that come with the herniated disc. You have to have inflammation to have the neck pain, the headaches, and then, of course, the arm pain. You have to have inflammation. So how could you possibly have inflammation from a herniated disc if there's no blood supply? And the answer is you cannot have inflammation with a herniated disc if there's no blood supply, which is why herniated discs that only herniate into the inner half of the annulus, so grade 1, grade 2 herniations, they never cause pain because there's no blood supply to the inner half of the annulus. But once they get to the outer half of the annulus, that's where the inflammation starts. And that's where you get radiculitis, which is arm symptoms, and that's where you get basically inflammation of the dura that goes up around the brain, because it's in the neck as well. And so that inflammation carries up around the brain, and it causes what's called cervicogenic headache. This is all the blue stuff, is all the herniation. I'm in the epidural space now, right up by the spinal cord. And this is why the Koreans stopped doing the surgery, the ones I know, is because they paralyzed a few patients. And it doesn't take many patients of being paralyzed from surgery to actually stop doing something. But there's a safe way to do the surgery. And the Koreans weren't doing it safely, in my opinion, the South Koreans. You know, they were doing it with the patient awake, moving around, which I don't do that. I put my patients to sleep. So that's one difference between myself and them. Another difference is there's other differences that are things that I do with the patient to ensure that they don't have those type of complications. And there's too many to list, to be honest with you. And it's not one thing. It's many differences in technique. But I was originally taught by the South Koreans how to do this. Dr. Seng-ho Lee, he was the president of Wuridal Hospital in South Korea. He taught me. He probably doesn't even realize that he taught me, but he taught me. Because at the time, they had no idea who I was. I was pretty much a nobody in the endoscopic world. But, you know, I was one of many people that were trained, but not many people do this surgery because it's just so risky and it's so difficult to do. I don't mean it's risky when I do it like this. All surgery is risky, all surgery. But what I mean is that the margin of error is so small that surgeons won't do the surgery because they just can't learn the technique safely on a patient who's alive without hurting them. So they don't do it. I learned the technique, and I'm not going to say that I'm more skilled than them, but you can figure out why I was able to learn it. But it has a lot to do with training, experience, understanding of anatomy, everything kind of put together. My point is that the only way a surgeon is going to learn how to do this surgery is if they're trained by somebody like me to do it. And the truth is that to learn how to do this surgery, you need about a year's worth of training. So the problem is most surgeons are not going to stop their practice, leave their families for a year, move to Florida where I'm doing these surgeries and stay with me for a year and basically earn a pittance while they're working here for me, which that's what I'm going to pay them. But they're getting in exchange knowledge and experience to do the most sophisticated spine surgery in the world for degenerative disc disease. So there's no way I'm going to pay them a lot of money. So they're going to end up, and by the way, it's not just me, but all fellowship positions, they don't pay the fellow a lot of money. It's an exchange. The fellow gets enough money to live, food, room, board, and what they're giving the business is their work, and what the business is giving them is knowledge and training. They're investing in themselves, right? That's what I had to do. You know, I had to take, when I was a neurosurgery resident at the University of Florida in Gainesville, it was the top program in the country and probably the world under Dr. Albert Roten, Arthur Day, Bill Friedman, Parker Mickle, Rick Fessler, Jeff Henn, Glenn Rechtine. Long story short, I chose the University of Florida because it was literally the best training in the world for neurosurgery. And I turned down Harvard and Columbia and Yale, a lot of the other Ivy League programs because they weren't as good. And basically, I invested 7 years of my life working at 110 hours per week, literally awake working in the hospital, 110 hours a week on average. Some weeks I would do 120 hours. That's on your feet running around caring for patients. That's not sitting around slurping on McDonald's milkshakes. That's hard work. I mean, literally nonstop at breakneck speed in the most complex type of care, which is neurosurgical care. So 110 hours a week, and I would get paid $35,000 a year. So in medicine, it's an exchange. You exchange your education and what you're trained to do in exchange for your work. And they steal literally 7 years of your life, your best years, and pay you $35,000 a year when you actually do probably about $2 million worth of labor for them. And I'm not complaining, I'm just telling you the facts. Those are the facts. And so if somebody wants to learn this technique that I'm doing now, they're going to have to come and train with me because this is not taught in normal neurosurgery residency. It's an advanced technique. It's a more recent technique. and there's only me to teach them. The problem is, by the time these doctors get done with their neurosurgery or orthopedic surgery training in residency, neurosurgeons spend 7 years, orthopedics 5. They don't want to come spend another year training on a technique. But the problem is this is truly the future of spine surgery. And this is really the best surgery in the world, much better than what's being done now. So what they should be focused on is learning what's the best treatment for the patients. And that's what I did. That's why I went out and learned this technique. I went overseas. I learned from the German doctor, Sebastian Reuten. I learned from Chinese doctor, Dr. Anthony Young. And I told you I learned from the South Koreans, from Dr. Seng Ho Lee. This is a bone spur, by the way, I just removed there. For those of you wondering, oh, can the laser get rid of bone spurs? Well, lasers cut through steel. Okay, we use lasers to cut through steel. So do you think they can cut through a bone spur? Absolutely. A bone spur and steel are not even close, right? A bone spur is much easier to cut through than steel. So if you look at my tubular retractor on the inside for my lumbar cases, you'll actually see where the laser has blasted through and melted the steel. That's surgical steel. So these lasers are very powerful, so don't let anyone tell you otherwise. That's the posterior longitudinal ligament down there, and most disc herniations don't pass through the posterior longitudinal ligament. They go up to it and push against it, and they create inflammation in the back of the disc, and that's what this patient has. She doesn't have massive extruded disc herniations. She has small disc herniations. So this is a piece of the herniation right there. And literally I have to paint it off of the spinal cord, because that's the spinal cord right underneath it. I have to paint it off with the laser. And this is where the South Koreans got into a lot of trouble. All right, and that's why I heard they stopped doing these surgeries. We have any questions yet, Sonny?
No, sir.
All right. Are you broadcasting?
I am.
Normally we have a lot of questions by now, so I'm not complaining. I'm just saying.
Yeah, no, we have about 8, 9 viewers. So
How many?
8 and 9 viewers.
8 and 9?
Yeah, 8 to 9 viewers.
Normally we have hundreds of viewers.
Yeah.
Why do
Light
we
day.
have such a low viewership?
Not sure. Light day today.
Are you doing something wrong?
No, sir. It's all being broadcasted to all platforms.
So, okay, that's fine. All right. So this is the foramen. That's on her left side at C6-7. We're looking out the foramen. There's a little bone spur in the foramen. I'm zapping away. But we got the herniation out already. And all you're seeing left is some blue stain. And honestly, I'm just about done here. This is below the nerve root right here. It's a little bit of hypertrophied ligament in the foramen. I'm just going to zap it down anyway because that will only help. And I have a real philosophy about not gilding the lily. For those of you who are wondering what I'm talking about, don't do more than you need to do to fix a problem. And the problem is if you start doing more than you really need to, then you're going to risk doing a complication. And we don't want a complication. I've had 0 complications with this surgery. I've been doing it now for 13 years. And I want to keep that record because I believe it's keepable if the technique is done right. And, you know, the surgeon exercises good judgment. And by the way, I'm not worried about the number of viewers because what happens ultimately is a lot of people will watch the surgery later on. You know, they just replay it. Usually within a day we have over 1,000 people that watch the surgery. So remember, neuropathy, N-E-U-R-O-P-A-T-H-Y. Look it up on Google or Bing. It's extremely common among diabetics especially, but there's about 30 different causes of neuropathy, and to be honest with you, what you really want to do is find out what's causing yours, because if it's diabetes, you want to get your diabetes under control. You need to get your sugar under control. If you do that, it'll stop it from getting worse. You're not going to ever get rid of it, but it'll stop it from getting worse. And you really want to make sure you stop it from getting worse. There are people who have advanced neuropathy where honestly they can't even stand on their feet. They can't put shoes on, socks on. They can't put anything on their feet because it hurts so bad. It's like a burning on the feet. And that's certainly likely of what's going on with you. I'm not saying you have diabetes, but there are other causes of neuropathy like a low thyroid hormone. There's like a whole list of things, 30 different things, and the neurologist needs to run blood tests to figure out why you have your neuropathy. You could have a low B12 vitamin. You could have a low thyroid thyroid hormone. So there's a bunch of different causes of neuropathy, and you want to prevent it from getting worse. And then there's, of course, medication that will make it feel better, but nothing cures neuropathy. The other thing it could be is a problem with your foot, like I said. It could be a plantar fasciitis. That causes burning. It could be a tarsal tunnel syndrome, which is a pinched nerve in the foot. So those are things that a podiatrist can investigate and figure out if you've got it. And then the other thing I'll tell you about neuropathy that my patients that have it have told me is that they use turmeric. Turmeric, it's a root, I think, right? Turmeric root. And they boil it, and they drink the extract, turmeric extract. And they say that that helps with their neuropathy. So that's just a little homeopathic plug right there for those people with neuropathy. They may want to try some turmeric. So we're getting a really good result here. I'm very pleased. Yeah, clearly a really damaged disc here at 5'6", really badly damaged. This is, I think, where most of her symptoms are coming from.
So he's following up. He's saying that he was sent to a foot doctor, and she said that it was from a pinched nerve.
She said what?
He went to a foot doctor and said that it was a pinched nerve.
A pinched nerve, but where? Where? In the foot or in the back?
Doesn't say.
So tell me where they said it's a pinched nerve. There's a pinched nerve in the feet called tarsal tunnel syndrome, and you have to have the nerve unpinched in your foot, or a pinched nerve in your back. And if it's a pinched nerve in your back, you're going to definitely have shooting pain down your leg, or numbness going down your leg, or tingling going down your leg from your back. If you're not having anything going down from your back, down your thigh, calf, into your foot, then it's not coming from your back. Your foot doctor is wrong.
Yeah, he said he has no burning, but only tightness in the feet.
Look at that herniation there. No burning where?
No burning on the feet, just tightness on the feet.
Oh, tightness in the feet?
Yes.
Stand by. I'm not sure why he has tightness in the feet. But the key is, do you have symptoms shooting from your back down your leg? If the answer is no, then it's not a pinched nerve in your back. Okay, if it's just in your feet, there's something else going on. The other thing that can cause cramping in the feet, if it's just cramping, is medication, especially cholesterol medicines, statins. So you gotta, I don't know if you're on a statin drug, but that's something you need to look at as well. We're almost done. I got 5 more minutes. I'll plan accordingly. How's my water pressure?
It's still good.
Well,
Okay, he followed up again.
yeah.
He has. He said, yes, I have some down my back, mostly on the left side. It gets really numb, and burns from time to time. It's not always, but it's there.
All right, good. Come see us. Set up an appointment to come see me. We'll figure it out. All right, so we're just finishing up the last bit here in the foramen. Things are looking good. I'm feeling good about this. That's out in the foramen right there. Way out in the foramen. When I say way out, I mean lateral. And then coming back to midline, you can actually see the dura right there. That's the spinal cord. You can see there's still some herniation towards the midline that we need to get rid of, and then we're going to be done. This is, see how the herniation's stuck down to the annulus? It doesn't want to come out. We want those pieces out. There's a herniation coming out. Okay. Come on. Watch the fiber.
Okay, he got a new MRI recently, so he's going to upload that to us.
Yeah, great. He needs to come in and be seen. Stand by. It's just for those people who are wondering, it's very difficult to make a diagnosis over video or over the phone, especially in a complicated case. You need to come in and be examined. So if you want the best, most accurate diagnosis of what could be going on, or list of diagnoses that are possible for your problem, you need to be seen and examined. A lot of doctors don't do that anymore. They just look at an MRI. MRIs don't tell you where, get the laser on please, pay attention. MRIs don't tell you where pain comes from, okay, unless you have a fracture. And then if you have an MRI and it shows a fracture, which is extremely rare by the way, then you know the pain's coming from the fracture. If they didn't have it before, now they have it, they being the patient. So otherwise, if you're talking about a degenerative condition, you're never going to figure out from an MRI just alone where the problem is. You need a physical exam.
We have another question.
Sure.
If pressure on a nerve causes pain to its supply area, what happens to pressure on nerves that supply, for example, organs in gastrointestinal or reproductive systems?
Yeah, so pressure doesn't cause pain. That's a misnomer. It's a misinformation. It's a fallacy. It's actually irritation of the nerve root that causes pain. Okay, irritation of the nerve. And the irritation that in the lower back or neck that causes pain down the arm or leg is inflammatory irritation, where the inflammatory mediators, cytokines, interleukins, are released in the process of inflammation, and they irritate the nerve. So specifically with radiculitis, which is irritation of the nerve root that causes arm symptoms like arm pain or leg pain like sciatica, that's due to inflammation of the nerve root. It's not due to compression of the nerve root. Compression of the nerve root causes weakness, numbness, and tingling. It doesn't cause pain. So not many people in the world know that. Most surgeons have no clue about that. But for those of us who really understand pain, we know that to be a truism. So as far as organs, you would have to have inflammation of the nerve root in the abdominal cavity to cause pain. But the thing you have to understand, and I've talked about this before, is there's two types of sensory nerves in the body. One is called somatic afferent, the other is called visceral afferent. somatic afferent nerve fibers go to a part of the brain that has like a map on it. Basically, it's called a homunculus. 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 And because those fibers go to the homunculus, they're called somatic afferents, meaning they bring sensory information from the body to the brain to a very specific region of the brain called the sensory homunculus. Sensory homunculus. It's basically, there's a map of the human body on the surface of the brain within the cerebral cortex of the parietal lobe, and that map allows the brain to know exactly where the pain's coming from, which is why you feel it in your specific location, like the lower back or wherever. Those pain signals are traveling along what's called a somatic afferent path, or somatic afferent fiber, because that fiber ends up transmitting pain information to the part of the brain that allows you to have a conscious understanding of its localization. That's really what makes up those nerve fibers. That's where people with back pain that I'm operating on, or neck pain that I'm operating on, that's what they have. They have activation of somatic afferent fibers in their disc from the inflammation going on in the back of the disc. Okay? You're not going to hear this anywhere else because nobody else really understands any of this. Very few of us in the world do. So don't expect to Google it and find it. But this is really the basis of most of my success at treating patients, is understanding that there's somatic afferents, they're triggered by inflammation, and they go to specific areas of the brain that map to those regions of the body, like the lower back. Now, visceral afferents are different. Visceral afferents, viscera means your organs. Those are pain fibers that transmit information about pain to your brain, but they do not go to the sensory homunculus. They don't go to the anterior parietal lobe, or called the postcentral gyrus, basically. They actually go to diffuse association areas of your sensory cortex. So there's no conscious understanding of pain because of that. There's no localization of pain. It just causes kind of a vague discomfort, all right? Now, appendicitis, for example, when you have a perforation of your appendix, initially it's very diffuse pain because it's visceral afferents. You can't localize it. You don't know where it's coming from. It's just a generalized abdominal discomfort. But once it perforates, once the inflammation perforates the wall of the appendix, then what happens is it triggers new fibers that are called somatic afferents that are in the lining of the viscera, in the wall, and that allows a better localization of where the pain's coming from. So that's why appendicitis, for example, always starts out as diffuse abdominal discomfort and eventually localizes to the right lower quadrant, because by the time it localizes, we're done. Somatic afferents are being involved with the inflammatory process, whereas when the inflammation is just within the lumen of the appendix, there's no somatic afferents, it's just visceral afferents. So it's only going to be a vague kind of feeling of discomfort, but not localized. So when you talk about the disc itself, okay, the disc itself has a front, sides, and a back, right? And let me have the dilator. It's the front of the disc is visceral afferents, the sides of the disc is visceral afferents, but the back of the disc is somatic afferents. And this is the key. This is the key to understanding discogenic back pain that really nobody knows about. Why do I know about it? Because I sat there for hours and hours and days trying to understand it, looking at textbooks, looking at pain fibers, understanding the innervation of the disc, things that most surgeons don't even care about. They don't pay attention to it because most surgeons don't operate for pain. They operate for pinched nerves, okay? Or pinched spinal cord or deformity. And the fact of the matter is that there's millions of people around the world that live in constant pain of their back or neck that are unfixed because these doctors haven't taken the time to understand the pathways and understand what's causing the pain. But we do at Deuk Spine Institute. I have, and that's why we're able to cure pain, is because we understand where it comes from, the source. The source of pain from a herniated disc is in the back of the disc, either back center or back sides. And the reason why it's painful is because there's a tear in the annulus that goes to the outer half. The herniated nucleus pulposus, or jelly from the center, is extremely inflammatory, pro-inflammatory. It gets into the outer annulus, outer half, and there's blood vessels there. Those blood vessels in your inflammatory system recognize the herniated material, the nucleus pulposus, as foreign. In other words, they say, what the heck is this? We've never seen this before. This shouldn't be here. Let's attack it. So they start attacking it. And by attacking it, they create inflammation. And the attacking goes on and on and on and on. It never stops. Now, in people who have a herniated disc where they have pain for a few hours and then it subsides, they've actually created a wall around the nucleus pulposus of scar tissue that has effectively surrounded it and isolated it from the blood supply, because scar tissue is avascular. Mature scar tissue is avascular. And so the people who have chronic back or neck pain from herniated discs have chronic back and neck pain because their bodies are unable to effectively wall off the nucleus pulposus, which is part of the herniation. And it's specifically the part that's stuck between the annular tear, which is called the interposed nucleus pulposus. That interposed nucleus pulposus in the outer half of the annulus is what elicits inflammation in the outer annulus, which is what causes back pain and neck pain from a herniated disc, and nerve pain from a neuritis or radiculitis, specifically where you have inflammation of the nerve root, and it's actually inflammation of the dura covering around the nerve root that actually is what causes the pain. So again, this understanding that I'm imparting to you all who are listening, and I know there are people listening in the medical profession, I'm teaching you the essence, the crux, the basis, the origin, the genesis of discogenic pain is somatic afferent fibers innervating the outer half of the disc in the back and sides, back sides, not sides, but back side, where most herniations occur. And that's why there's back pain. Now, 99.9% of my colleagues have no clue about this, and they would probably think that, very interesting. But it won't change anything that they do, because they don't care about people's pain. They don't care about fixing pain. They just care about clipping aneurysms or removing AVMs or taking out brain tumors, things like that. But I've dedicated my entire career now to fixing pain, because I think living in pain every day is torture for people, and I've seen it destroy their lives. As a matter of fact, one of our patients who was waiting to have surgery did not wait any longer. And today is a very important day at Deuk Spine Institute, and a very sad day, a tragic day, because we were supposed to have 2 surgeries today, and the patient who was going to have their second surgery on their neck to fix their neck pain committed suicide yesterday, and did not wait. And had she waited just a little bit longer, we could have fixed her pain. And it makes me so angry that this happens to these people, because there's so many people like that I don't even get the message out to, that I can fix their pain. And they don't make it here, and they end up taking their lives because they're living in pain and suffering every day. And so I take pain very seriously, and I've dedicated my entire life to fixing it. And that's what Deuk Spine Institute is. It's about helping people get out of pain so they can get a normal life, and not have their lives destroyed or their loved ones' lives destroyed by their pain. So that's why we broadcast. We want the world to know that pain is fixable in the neck and back, and it just takes the right surgeon, the right surgery, the right procedure to do. All right, we're done with the surgery now. Why don't you, Sonny, take a look at the incision? I've been holding pressure on the neck because we don't want any venous bleeding. And you can see the incision is right here. It's 4 millimeters. And we're going to put a Band-Aid over it, and we're done. The neck is supple. There's no blood clot. Everything went really well. I'll be over to the conference room in a few minutes, and I'll answer any more questions. Huh? Thank you. Thank you, everybody. Good work.
I ended up calling them. They said it's latex free.
Oh, thank you. Nice job. I like that initiative.
At least know.
Yes. We need to know. I'm going to call our EBL 2 mils. So we did a left-sided C4 to 7 RFA with Dr. Patel. And then we did the DLDR. We did a right approach. C5, 6, 6, 7. Thank you, everybody. Nice work, nurses. No, everybody did a great job. Oh, my mic is still on. I'll be right there. Morning, everyone. This is Dr. Ara Deuk-Machen, CEO and founder of Deuk Spine Institute. If you're watching live today being with you. I'm in the control room now, sitting next to Sunny, because Zach is not here today. Normally Zach does the broadcast for us, but Zach is on vacation. And I've got Sunny here. Sunny is the head of IT for Deuk Spine and a good friend of mine. And my gosh, Sunny, how many other things do you do? You fix the air conditioning system. Yeah. Aquarium, you know, the lights for all the corals, and he's anyway, Sunny wears many hats, as do many of my employees. So we just completed a Deuk laser disc repair, cervical spine. Patient's right side is where we went in, so we call it a right approach, because we approached the spine through the right side. We did a 4mm skin incision. We went through with a metal tube that we did the whole surgery through, a little metal tube. And again, this is the future of spine surgery we're watching right now. So this is kind of like, you know, the first time that stealth technology was rolled out, the whole world went, oh my God, what is that? I mean, I still remember it when I was a kid, and they came out with the first stealth technology. They announced it. I'm sure they had it for a few years before they went public with it, but the point is nobody really knew anything about it. Nobody had ever seen it before. It was totally new, and obviously it was a big deal. And so these surgeries that I'm doing, endoscopic spine surgery, is a big deal. It's kind of like the first time a surgeon ever did an arthroscopic knee surgery. There was a surgeon, there was one doctor in the world that did it for the first time. And basically, I am that doctor, not the first time for the cervical endoscopic or lumbar, but the Deuk laser disc repair, I guess you could say I'm the first one to do the Deuk laser disc repair, which is a specific type of endoscopic surgery done a specific way. And so I truly believe that the Deuk laser disc repair procedure is going to be what all the surgeons are going to be doing in the future to fix herniated discs that are causing symptoms. Right now, what pretty much every surgeon in the world is doing is either an artificial disc or a fusion with a cage and a metal plate. And the problem with those surgeries, to be honest with you, is that the plate, the cage, the artificial disc, completely unnecessary. to fix a patient's herniated disc. All you have to do is leave the natural disc there. Even if there's not much natural disc left, you leave it there, you go past it with the tube, and you get to the back where the herniation is, and that's really what every surgeon is trying to get out, is that herniation in the back, a herniation and bone spur. We call it a disc osteophyte complex. Anyway, the laser is perfectly capable of removing disc osteophyte complexes, which is really a combination of disc herniation and osteophyte. So the whole surgery of cervical disc herniation, lumbar disc herniation can all be done endoscopically. In the lumbar spine, lower back, we do transforaminal approach, which is through the flank sideways, coming at 45-degree angle to the spine, going through a natural opening. So there's no bone removal like they have with microdiscectomy or laminectomy. Honest to God, folks, I can fix 98% of neck problems and back problems, not talking about fractures, tumor, or infection, but herniated disc problems. I can fix 98% of them in the neck and back with the endoscopic technique you've seen today. And if all the surgeons in the world were suddenly trained and knowledgeable, they had the knowledge and training and skill that I have at doing endoscopic surgery, they would all stop doing fusions tomorrow. It literally, you would hear the metal clanking on the floor because it would never be used again. It would literally never be used again. So all I do is spine care and do spine surgery, and literally virtually every single patient I see that needs surgery could be done endoscopically without any fusion, without any metal, without any implants. I'm certain of that. The only reason all the other surgeons are using metal and doing fusions and artificial discs is because they don't know how to do the endoscopic surgery that I do. And do they know how to do it, they would do it. There is one other issue, obviously, and that is not all the insurance companies know about this surgery, so they don't all cover it. So that's a secondary issue. Now, unfortunately, some surgeons, and it's true, and they should get paid, but some surgeons won't do surgery they're not paid for. So long story short, I had to do many of these surgeries in the beginning where I wasn't paid. I did them because it was the right thing to do for the patient, and because, you know, we needed to advance the technology. So that's why I did the surgeries. But now, today, in this day and age, unfortunately, we've got a situation where most people don't know how to do the surgery, and it's literally going to take at least 10 to 20 years before they learn how to do it. So, all right, do we have any questions, Sonny?
Yes, sir.
It's been a pleasure spending time with you. We'll check on this patient once she's awake and doing well. Thank you.